Thank you for joining today's webinar, Exploring Opportunities to Address Healthcare Costs Through State Employee Health Plans. I'm Vicki Veltri, and I'm a Senior Policy Fellow here at SEHP, the National Academy for State Health Policy, and I'm going to moderate the webinar today. We know these are really busy times, especially for those of you out there who are representing state employee plans or finalizing preparation for your open enrollments and looking ahead towards your next legislative sessions. We appreciate all of you coming today to learn more about states' efforts to curb healthcare costs through employee health plans. Before we begin, we'd like to take a moment to thank our funder, Arnold Ventures, for making this event possible. So for those of you unfamiliar with us, the National Academy for State Health Policy, NASHP, is a nonpartisan organization committed to developing and advancing state health policy innovations and solutions to improve the health and well-being of everybody across every state. Our work covers a broad range of topics, including a dedicated center for hospital health system costs, and regular support for our state employee health plans, which is the focus today. So on slide 3, as I'm sure many of you are aware, rising costs are an increasing problem across our healthcare system. Employers are among those grappling with the brunt of this issue, and some experts are predicting that 2024 will see the biggest leap in employer healthcare costs in over a decade. States are among, if not the largest employers across populations, and rising costs of their benefit packages pose significant implications for state budgets, employees, and taxpayers. With this in mind, we're very excited to bring you our esteemed panel today. First, we have Sabrina Corlett and Karen Davenport of Georgetown Center for Health Insurance Reforms here to share more information from the recent survey of state employee health plans, focused especially on state cost containment efforts. Following Sabrina and Karen will be presentations by Galen Benshoof, Enterprise Director of Employee Insurance for the Minnesota Management and Budget, and Laura Smoke, Analytics and Health Initiatives Director for the South Carolina Public Employee Benefit Authority. So a couple logistics before we start. I know everyone is familiar with the logistics, but we're going to go over them again. All of your phone lines have been muted to minimize background noise. We encourage you to post any questions or comments using the chat function. We will try to get as many questions or comments as we can during the webinar. We are recording it, and the slides and recording will be available on NASHP's website within the week. With that, I'm going to turn things over to Sabrina, followed by Karen at Georgetown. Sabrina, take it away.
Vicki, thank you so much. And thank you to NASHP and my fellow panelists for the opportunity to be with you all today and talk about how state employee health plans are trying to improve affordability for their employees and their families, and how some of those strategies can really have spillover impact for the rest of the commercial market. Next slide, please. For those of you not familiar with the Georgetown University Center on Health Insurance Reforms, we are based at the McCourt School of Public Policy at Georgetown, and we are a team of people that focus on private health insurance. We do legal and policy analysis of federal and state regulation of health insurance and market trends. And in addition to publishing a lot of research reports, including the survey that we'll discuss with you today, we also provide technical assistance to state officials and other healthcare stakeholders. Next slide, please. So why are we talking about this? Just to do a bit of level setting before we dive into the survey findings and the discussion, I wanted to share with you the latest data from the KFF Employer Health Benefit Survey. It's now in its 25th year. I imagine many of you are familiar with it if you follow employer-based insurance issues. It's an incredible resource, incredibly comprehensive source of information about what is happening with employer-based insurance. And as this graphic shows it's pretty stark terms what has been happening. The bottom blue line represents overall inflation. The next black line represents workers' earnings. But if you look, you'll see that both family premiums and in particular deductibles are the growth there is significantly outpacing both workers' earnings and general inflation. Next slide, please. Why is that? Well, if you ask any health economist or anybody that is studying the drivers of health system cost growth and the growth in premiums and deductibles, it is prices and not consumption that are driving up healthcare costs. This graph shows, this slide shows the headlines from two seminal articles in Health Affairs, just saying it's the price is stupid. That is what is driving up costs, and it's primarily in the areas of hospital care and prescription drugs, driven in large part by the tremendous amount of horizontal and vertical consolidation that has occurred among healthcare providers over the past several years. Next slide, please. In particular, we're seeing hospital costs are the primary driver of healthcare cost growth in this country. I think this slide does a great job of illustrating it. And if the font size is too small on your screen, you can just see this graphic shows you some price changes between January 2000 and June 2022. At the tippity top of the graphic is the price of hospital services, number one. Other consumer goods and services such as TVs, computer software, toys, clothing, etc. Actually becoming more affordable over time, but hospital services are clearly outpacing pretty much any other consumer good or service. Next slide. Close second here is prescription drug costs, just a major cause for concern for employers. Just in the last year, eating up from 21 to 24% of employers spend on health benefits. Next slide, please. So that bit of background takes us to the survey that Georgetown did of state employee health plans. Next slide, please. So we fielded a survey both in 2020 and again in 2022. Both were supported by Arnold Ventures. And we wanted to ask state employee health plans not only about the benefits that they offer to employees and families, but also what are they trying to do to constrain healthcare cost growth and keep that coverage affordable, not just for workers, but also, of course, for state taxpayers. And why did we want to focus on state employee health plans? Number one, they are often the largest commercial purchaser in the state. Number two, with their size, they can act as a stimulus for broader system changes. And for state policymakers, they can often be perceived as a key lever for policies to address affordability challenges. Next slide, please. So our survey report with all the findings, as well as interactive maps and data tables, are all available at this website, SEHPcostcontainment.cheer.georgetown.edu. I encourage you to check it out and poke around. You'll see lots of rich and interesting information about your state and other states. We got 50 responses from states in our last survey. Just some big picture takeaways between 2022 and 2020. We heard from a lot of states that during COVID-19, utilization of services was relatively low as people delayed or forewent care due to the pandemic. At the same time, state budgets became flushed with an influx of federal COVID relief money. And so there really was minimal pressure on state employee plans to restrain cost growth. But in our 2022 survey, we heard that was really starting to change. And many state employee plan administrators told us they were bracing for premium jumps for 2024. And as Vicki mentioned, indeed, many are experiencing those jumps. Next slide, please. When we asked state employee plans to tell us what was the single highest cost driver that they identified in their plans, it was essentially the top two were prices of prescription drugs and prices of hospital services, which is not surprising given what we heard in the earlier slides about what is driving healthcare cost growth. Interestingly, excessive or inappropriate utilization was identified by only 2 states as the top driver of healthcare cost growth. Next slide, please. So in light of that, we thought it was interesting that when we asked states to tell us what cost driver were they targeting in their cost containment strategies, we found that all of a sudden, excessive or inappropriate utilization starts to rise to the top. So while prices of prescription drug was the top strategy, targeting excessive or inappropriate utilization, whether that's through higher cost sharing or higher deductibles or wellness programs, that became the second highest targeted strategy, even though the prices of hospital services was a major cost driver. Next slide, please. And indeed, when we ask states about the top 10 cost containment initiatives they have implemented over the last 5 years, only 2 on this slide, I think, really have the potential to target hospital prices. And indeed, the top 4 strategies are primarily about containing excessive or inappropriate utilization of enrollees. So there's a bit of a disconnect between what exactly is driving cost growth and the strategies that states are pursuing. Next slide, please. That said, the state employee plans are really trying a lot of different strategies, and I think leaning into efforts to try to keep their coverage affordable for their enrollees and for the state taxpayers. So we heard from, as many as 14 states are trying between 11 and 20 different initiatives to try to keep cost growth in check over just the last 5 years. I'm going to turn the next slide over to Karen to finish up our survey findings.
Thanks, Sabrina. I am going to talk a little bit about, really do a hybrid of our survey findings, and then we also had the opportunity to talk with administrators from about 12 state employee health plans to, allow us to have a richer understanding. Yes, back one, thank you, of some of their experiences with cost containment initiatives. So I don't have any more handy tables, but I will fill in a little bit more. First, more than half of the states reported that resistance from stakeholders is a major impediment when they're trying to develop a new cost containment initiative or get it off the ground. An obvious example would be providers who might resist lower or different payment methods. But during our interviews with SEHPs, we also heard a lot about the third-party administrators who the SEHP plans characterized as often neither an agile nor willing partner in cost containment. And I'll say a little bit more about that in a minute, and also members themselves. So, a new cost containment plan may ask enrollees to change their behavior or change providers or pay more out of pocket for certain services or providers. And SEHP administrators were very attuned to members' preferences and concerns about these changes. And they try to, mitigate and minimize what some of them described as member friction when it comes to cost containment. They were also highly cognizant of the administrative burdens that are related to certain cost control strategies, and that was something that they considered a lot. Other issues that came up as barriers to cost containment issues were the statutory or legislative constraints around that govern their program and limited evidence on return on investment. So were both barriers to change. In interviews, several SEHP administrators discussed their limited in-house capacity for evaluating programmatic changes and the challenges they have faced accessing data for this analysis, including obtaining this data from their TPAs. Other commonly cited barriers to cost containment included the SEHP plan's governance structure, procurement requirements, and then the collective bargaining agreements that might exist in the state with the public employee unions. Go ahead to the next slide, please. So to talk a little bit more about third-party administrators, we found that most SEHPs receive claims data from their TPAs, and then most of those plans use this data to understand cost drivers. We also found that most states have built cost containment goals and accountability mechanisms, such as financial incentives, into their TPA contracts. At the same time, we heard complaints about relationships with their TPAs during our interviews with the SEHP administrators. And as I just noted, SEHP administrators did not see TPAs as necessarily their partners in cost containment, in part because they perceived TPAs as offering them the same expensive and off-the-shelf strategies that they offer to other employers rather than working with SEHPs to create tailored cost containment approaches. They also noted that they had trouble accessing quality data and race and ethnicity and gender data that they needed to inform cost containment strategies and improve their ability to address health equity. Next slide, please. And then to touch a little bit more on data, as this audience likely knows, the transparency and coverage regulations require hospitals and health plans to publicly post the rates they charge and the prices they pay for healthcare services. Most SEHPs, however, reported that they're not yet accessing or using this data. For both health plan and hospital data, they cite, as they did in terms of evaluating return on investment, a lack of internal capacity for data analysis, and some note that they are not sure that it would be worth their time and effort, whether what they would learn would be worth what it took to undertake this analysis. On the other hand, 7 states plan to use insurer price data in contract negotiations with their TPAs, and 1 state plans to use hospital data to inform its next steps on cost containment. So those are steps states will be taking with this data. We also asked whether states are using other analytic tools, such as NASHB's interactive hospital cost tool, and 9 states reported using these resources as part of their work on cost containment. Next slide, please. So while only 15 states told us that they were able to document demonstrated savings from their cost control efforts, states also, they did share the initiatives that they have either expanded or discontinued based on that kind of analysis. We learned that 5 states, for example, have discontinued their wellness programs, but in contrast, 1 state has expanded its wellness offerings. Other expanded cost containment efforts include disease management programs, site-neutral pricing, and patient-centered medical homes, among others. And then discontinued initiatives included efforts to create differential cost sharing for high-cost providers, second opinion requirements, and new payment approaches for primary care. And there you might see some of the initiatives that cause a little bit of member friction or other issues with stakeholders as well. If you can go to the next slide. So through our interviews and the survey responses, we identified 3 particularly promising cost containment strategies that are, not only used, but being used more by some of the state employee health plans. The first, reference pricing, not only generated significant savings for the SEHPs who we interviewed who would use this, but they also noted that they found it to be easy to implement and administer while generating little or no pushback from providers. Tiered networks, which enable SEHPs to steer or nudge enrollees to higher value providers based on price and quality, were characterized by SEHP administrators as more acceptable to their enrollees than narrow networks, and yet they are generating savings in comparison to the traditional PPO networks that their plans had been employing. So we found that 14 SEHPs now offer tiered networks to their members, up from 9 in 2020. And then the third strategy, multi-payer partnerships with either government purchasers or employers, can be more complicated to get off the ground given the kind of collaboration they require. But at the SEHP administrators who are engaging in these partnerships were really enthusiastic about their potential for meaningful change, both in terms of savings, but really also about driving change within their state's delivery system. While only 5 states are undertaking this kind of work right now, their results are, I think, are going to be of interest to other states. And next slide, please. So to highlight a little bit of the lessons we learned through both our survey and our interviews, I think we really saw that SEHP administrators work hard to communicate with both their network providers and enrollees as they design and roll out cost containment strategies, and that work is really critical to success. Evaluation is so far an important but under-resourced component of SEHP cost containment initiatives, and closely related to evaluation, SEHPs report challenges accessing and working with key data, including in some cases claims data and quality data and the new transparency and coverage data. SEHPs balance competing demands and often end up creating a more administratively complex program in order to address enrollee preferences and to address provider concerns as well. So they are looking to mitigate backlash, and that often can lead to greater programmatic complexity and perhaps lower savings than you might otherwise expect with the approaches they're taking on. And then finally, SEHPs find it challenging to work with TPAs and other vendors, such as wellness vendors, for example, as they work on innovation and cost containment. So that is the kind of summary of our work, and I will toss it back to Vicki. Thank you so much for your attention.
Thank you so much, Sabrina and Karen, for that really wonderful overview of the state employee health plans. I encourage people to put some questions in the chat, as when we get to the Q&A period, we'll have time to ask Sabrina and Karen questions as well as our wonderful next guests. So we're gonna move on to hear from a couple states on the work specific to their states. And first, we're gonna turn to Galen Benshu from Minnesota. So off to you, Galen.
Thank you, Vicki. Good afternoon, everyone. I'm Galen Benshu. I'm the director of Minnesota State Employee Health Plan with about 130,000 covered lives in our state. And I want to start my presentation with just a little bit of context on this next slide. So, as everyone listening in here already knows, healthcare eats up ever-increasing shares of the budgets of public employers and private companies alike. And in a vacuum, we all want to contain spending, but getting there is the hardest part. Most self-insured employers, including state employee health plans, outsource most, if not all, cost containment efforts to third-party administrators, which are usually a business arm of a health insurance company. And according to Georgetown's report, in about half of all state employee health plans, TPAs are exclusively responsible for negotiating with providers and developing managing plan networks. On top of that, the three most popular cost containment strategies mentioned in the report all typically rely on the TPA as well. And then in the next slide, I want to pose a couple questions. So few of us stop and ask why we almost exclusively rely on TPAs and what we should reasonably expect them to be able to achieve on our behalf. So in my presentation today, I want to tee up two questions from a conceptual standpoint before getting into the specifics of our model here in Minnesota. So here's my first question. Is cost containment within the interest of your TPA? It isn't a given that they'll be working hard on your behalf to contain costs, especially if you don't closely scrutinize your claims data or include performance incentives in your contracts with them. Or it may not even be in their business interest to effectively contain your costs, although it's really hard to know if that should be a concern for any given plan, since business interests are often hidden from outside view. So on to the second question. Should be able to advance. There you go. Thank you. Is cost containment within your TPA's power? There's scant evidence for disease and case management making any meaningful difference for cost. And on top of that, contracting strategy matters. If your TPA focuses mostly on prices, providers still have an incentive to increase services to maintain their revenue. And lastly, if you prioritize an open access network or your provider market is monopolistic, TPAs may have little negotiating leverage. So you could have the strongest performance incentives in the world in your TPA contract, such as a trend guarantee, which would satisfy question one. But if the TPA doesn't have the ability to meet those performance measures, it won't matter. You'll get paid whatever penalty you include in the contract for them not meeting that trend guarantee, which is nice, but it isn't really a long-term solution to the problem of cost growth. So on this next slide, I'm going to mention why this is a particularly opportune time to be talking about TPAs. They're getting more scrutiny than ever before. The report that Georgetown put together noted that a bunch of states reported challenges with TPAs. And as many of you have probably seen in the news recently, some employers have found things so concerning with regard to their TPA performance that they've gone so far as to file lawsuits. Partly spurred by the fiduciary duties that employers have under the CAA. And in light of that, I would argue there's no better time to be asking these hard questions of TPAs right now. So on the next slide, I want to come back to those two questions for a second, to think of them in light of employers' increased responsibilities. To the extent that the answers to these questions are even knowable at all, which is tough, if your cost containment strategy relies mostly on your TPA and the answer to either of those two questions is no, then your cost containment strategy will fail. Some employers offer multiple health plan options in an attempt to stimulate competition among them, but often what they're competing for is lower cost growth, which again gets back to the question of whether any of them actually have the power to achieve that on your behalf. Worse, they may attempt to conjure power the only place they really have it, oftentimes, which is utilization management. So if your model relies on health plan competition, and premium amounts are what they're competing on, what you've done is create a perverse incentive for them to go overboard on prior authorization, for instance, meaning that while your plan could save some money, some money, your members may suffer. So I recommend that plan sponsors think hard about what exactly you're using a TPA for and what realistic expectations should be for what they alone can accomplish on your behalf with regard to cost containment. So for most employers and TPAs under current conditions, the answer is likely to be not that much. So given that, what is the alternative? On this next slide, I pose the question, who does have the power to affect your plan's spending growth? And if you advance slightly, the answer is the providers themselves. So whereas TPAs may not have the interest or power to do much about your cost growth, healthcare providers obviously do, and primary care providers in particular. And for plans such as ours here in Minnesota that use a gatekeeper model, PCCs have substantial power. They're the only ones across the whole system with the direct ability to modify the prices charged to payers, the services provided to members, and the specialists to whom they're referred. But obviously, containing costs is usually not in their interest. So instead of relying solely on the TPA and banking on the unlikelihood that your plan's cost containment is desirable and achievable for them under current conditions, employers have the power to influence those underlying conditions. On the next slide, I want to talk a little bit about benefit design. Often state employee health plans are the largest employer purchasers of healthcare within the whole state. That means your scale is powerful. And there are a few different ways to stimulate provider competition. One is through narrow networks, requiring that your employees go to providers where your TPA can get the best deal, for instance. But as we all know, employees don't like narrow networks. And alternatively, you could maintain a broad network while at the same time using financial incentives to encourage members to use the most cost-efficient providers. Unlike in fully insured products, self-insured plans like ours have the ability to modify our benefit design and provider networks, although some elements of it may be collectively bargained or mandated by law. And on the next slide, we'll talk a little bit about benefit design strategies. So historically, health plans and self-insured employers have used benefit designs, usually through higher and higher deductibles, to reduce premium costs and or to ask members to self-manage their own utilization, usually to poor effect. So those are zero-sum approaches to the problem of cost and don't do anything to achieve sustainable cost containment. On the other end of the spectrum, many plans opt to not change much of anything, keeping cost sharing low and access wide open, whether by intentional strategy or simple inertia. All benefit designs affect utilization in one way or another, including what you all have in place today. And your members, our members' patterns of seeking care are influenced behind the scenes by their out-of-pocket cost or lack thereof. So what do I mean by that? If you have high deductibles in your plan, you are likely dampening the utilization of some important high-value services. Conversely, if you have low cost sharing across the board paired with an open network, what you're doing is promoting the use of higher cost providers, since most people mistakenly associate high cost with high quality. I recommend that you develop an articulated goal for your benefit design. What are you hoping that it does, and what are you hoping that it does not do? Again, your benefit design is already affecting member utilization, so why not adjust it and better align incentives for providers and members alike? So one more slide on benefit design before getting into some Minnesota specifics. So to give your members a reason to choose one provider over another, it has to be in their financial interest to do so. And that means cost sharing differentials across providers. A tiered network is one way, but not the only way to achieve this. And again, Minnesota does have a tiered network, and I'll get into that in a little bit in a minute. But just to wrap on this slide, so cost sharing differentials create positive incentives for your members, but it also does the same for providers. Members want lower cost sharing, and providers want patients. So here I have a basic 3-tier example showing how you can align those incentives. However, if you can't do this through employee out-of-pocket cost sharing, you could theoretically also do this through premium differentials. For example, a greater employer contribution to the premium for enrolling in a high-value network plan. There's a couple different ways you could do this. So on the next slide, I have a snapshot from Minnesota's benefit design. As you'll see in the red boxes, I have a couple of examples. So the first red box at the top, deductibles and copayments are lowest in our cost level 1, slightly rising in cost level 2, all the way up to cost level 4. So the difference between family deductible across these 4 cost levels is $500, $800, $1,500, and $3,000. So these are really meaningful cost differences. In Minnesota, we ask members to make one choice every year that affects their out-of-pocket costs, just one. And that is selecting a primary care clinic during open enrollment each fall. And members have to get primary care at that clinic, and they also have to get referrals for most specialty care through that clinic. All of the care they receive throughout the year is charged at that chosen cost level. Even if they are hospitalized at the most expensive facility in the state, they pay what the cost level of what they're enrolled in, what their primary care clinic in. So that means that members know exactly what they'll have to pay for care, for all their care throughout the year. And I did want to add one last thing on this slide. Most of our members, almost 90%, select a primary care clinic that's in cost levels 1 and 2. So clearly there's high demand for those more, for that lower cost sharing, meaning for those more cost efficient clinics. So on the next slide, I want to talk a little bit about how we are aligning incentives for our members and for providers. So we measure provider performance using total cost of care, which considers unit cost, utilization, and referral patterns. Including all 3 of those factors limits those perverse incentives I was talking about earlier. For instance, if we didn't include a utilization factor, providers could just increase the number of services they provide or upcode to regain the revenue they miss out on by being held accountable for price. Steerage through benefit design has been adopted by some other state employee plans, including a design specific to hospitals and particular procedures such as joint replacements, but I believe that the use of total cost of care to measure providers is rare. And a plan using a tiered network and total cost of care, like we do, creates the right incentives for both members and providers. So contrast that with high deductible plan designs, which hold members accountable for reducing improper utilization on their own, and then contrast also with the broad open access network with low cost sharing across the board, where members have little reason to seek high value providers, and also where providers have little reason to manage the total cost of care for their members. So on my last slide, I want to come back to TPAs. So we in Minnesota, we ask a lot of our TPAs, but it's really more about administrative complexity than cost containment. And some of those complexities include tracking positive member attribution, meaning the clinics that people sign up with, ensuring appropriate referral documentation, maintaining what is essentially 4 plan designs in one with our tiered network, and so on. But we try really hard to not put unrealistic expectations on them. Certainly other TPAs may not be interested or capable of implementing a model like ours, but I want to close by coming back to those 2 earlier questions and recommend that all plan sponsors be clear-eyed about what your TPA or what any TPA is capable of on its own, and then build your cost containment strategy around that, using the tools available only to you as the plan sponsor. I think that's all that I have. Thanks so much for listening.
Thanks so much. Thanks so much, Galen. You're giving everybody a lot to think about, a lot to digest when you're thinking about your strategic use of your network, your benefit design, and the role of TPAs. These are some of the tools state employee health plans have in their toolboxes to try to reach in and impact costs. We're going to shift gears now to hear about a few different approaches, and I'm going to hand things over to Laura Smoke from South Carolina to talk about multiple initiatives she's using down there.
Hey, good afternoon. I'm Laura Smoke, and I'm with the State Health Plan in the state of South Carolina. And my presentation today is going to focus on some cost containment initiatives that we have undertaken, some pain points, you could also call them pressure points, that we're looking at and monitoring, as well as some solutions that we're looking at and strategies on how to address those pain points. Next slide, please. Just for a little background, while the State Health Plan has been around for years, we are a relatively new agency in that we merged with another state agency and became the Public Employee Benefit Authority. That was in 2012, and we're now governed by an 11-member board. We are the plan sponsor of employee insurance and retirement programs. I'm on the insurance side, and so we offer the State Health Plan, which is a self-funded group health plan for active and retired employees, their eligible dependents of approximately 830 different entities, which are listed in this bullet. We cover currently about 10% of our state's population, so we're right under 530,000 lives, and that also includes our Medicare primary members as well as their eligible dependents. Next slide. The presentation today is we're really going to focus on our third-party administrators and current contract changes that we've got coming up next year. We just recently renewed our TPA contract, which manages and administers the medical benefits. We do have a separate PBM for our pharmacy benefits. And then I'm going to focus on some strategies and some initiatives that we've undertaken under the medical side of our plan, based around patient-centered medical homes, and then I've got a slide at the end about site-neutral pricing. If time allows, we can go over that as well. And then on the pharmacy side, I do want to talk about the patient assurance program and how it started, and kind of what our strategy around that, how it started, how it's going, and what we plan to do about it. And then the other 3 bullets are things that, if time allows, I'll touch on a little bit there around specialty medication, limiting that to a 30-day supply per fill, a Medicare Part B solution we implemented, and it's just really maybe some insight on our pharmacy benefits manager contract that we've got in place currently. Next slide, please. The new contract starts January 2024, and this again is our TPA for the medical benefit. We've challenged them with 4 new strategies for the upcoming contract, where we want to strategize in providing the DM program that's more reflective of our plan's diversity. And we also want to do that with our population health management programs. In other words, are we capturing everyone we should be capturing versus maybe just the worried well? And really look at how can we reach the folks, our members, that need and can benefit from our DM programming and our population health programs that are available to them. Another strategy we have is to address low value services within our patient-centered medical home program. We're looking at trying to identify those services. What are they? Are we paying for them? I think we know we are paying for some. And what can we do about how can we address those services and continuing to pay for them? And lastly, with the TPA, we are working with them to implement a social determinants of health program using best methods. We're going to focus on our non-Medicare primary members. I think we're all aware that there's some initiatives already in place to hit the Medicare primary members. So we really want to focus on those non-Medicare primary members for our state health plan. We've already started discussing that strategy with our TPA, and we're going to start slow, see how that goes, and then just keep building that program throughout the life of the contract. One of the first ones that we're going to look at is isolation, and we're excited about this new initiative and look forward to getting going on that. Next slide, please. One of our biggest initiatives that we have in place and have had in place for a while now is the patient-centered medical home. It started in 2009 with one primary care practice with about 500 members. And as you can see, that program has grown to over 8,000 practitioners, serving almost a little over half of our adult and pediatric members. So it has certainly grown in size. When we first started this program, there was a certification in place around NCQA certification, and then Blue Cross switched to using their own certification process. And part of that certification is looking at quality of care, cost of care, and sharing of clinical data. And then they look at enrolling them as a PCMH provider. The providers receive a risk stratified per member per month care coordination fee for their patients. And I'm going to talk about that in a minute and the impact that that's had on our spend. But right now there's a 3-tiered risk reimbursement based on shared savings arrangements. So the provider can decide which risk sharing arrangement they want to be in. Most of them are upside only, but we do have some that are going up and down. In 2016, the plan made a decision to incentivize care at the PCMH. At the time, we did not have as many practitioners certified as a PCMH. So we began waiving the physician office visit copay, which right now is $15. So if a member goes and sees their primary care from a certified PCMH, we waive that per visit office copay. And then we also have changed the coinsurance amount to the plan paying 90% versus 80% coinsurance. With more than 50% of our members going to a PCMH provider, you can imagine the effect of the bullet above has had an effect on our plan cost. It's more pronounced. With the recent increase in the per occurrence office visit deductible, the portion of our spend has grown considerably relative to 2022. It's 72.11% compared to 71.66%. So the plan has certainly picked up more of that spend than in the past. And this ratio has historically grown 0.2% per year as opposed to 0.6 as shown from 2022 to 2023. I'll just throw out some numbers that I think are very interesting. We just looking back at 2019, the share of the cost of the care coordination fee that I mentioned was 5.5 million. And then in 2022, it has grown to 11.8 million. So you can see significant growth in that care coordination fee, that per member per month that we were paying. The coinsurance has grown from 6.1 million to 13.6 million, same time period 19 to 2022. And the patients have grown from 136,000 to the current 265. All combined, the spend for the care coordination fee and the waiving the office visit copay, and the co-insurance increase has grown from 11.7 million to 25.4 million. So it certainly has grown. We're in the process of evaluating the PCMH program because of that, particularly in respect to the cost, the utilization, and the outcomes. So we've started this initiative to start the evaluation. We're working closely with our third-party administrator to develop a good way to measure the effectiveness of the program. Next slide, please. This is on the pharmacy side, the patient assurance program. Some of you may be familiar with this program, but this program was brought to us and recommended to us by our PBM, and it was presented with a thought to address the national concerns over the high cost of insulin. We implemented this program in 2022, and basically it limits the monthly copay to $25, which was below the current cost share that's in place. So the current copay that the member pays, which is $42. Originally, the program, when it was first introduced in 2020, only had 5 insulin products, but very soon thereafter, the program was expanded. And now we have 22 products in all, including the very expensive GLP-1s that I think are impacting everyone across the nation. Expenditure growth in this GLP category has skyrocketed since the inclusion in the program, and it's been a major cost driver with the plan over the past year. I will tell you that the GLP-1s alone cost $160.5 million year to date in 2023, with approximately 27,300 patients, unique patients using those. Since implementation, we've observed a major shift from generic products to more brands, and we've even noticed a slight backsliding in diabetic-related complications. So as a result of just the increase in cost and what we have seen as the less than satisfying results of the program and related to diabetes-related complications, we've made the decision to discontinue this program in 2024. So we're not at all, if we'll put it in place, if it doesn't work, we will certainly can end the program. Next slide. In summary, and if we have some time, and I'll let the moderator tell us if we have some time to continue with some of our other things, but in summary, you know, our staff were unique in the sense that we have a very robust analytics team. We have access to our own claims, so we can do a lot of the analytics in-house and rely less on our vendors, our TPA, our PBMs. We work with them, but we can also work on our own, and the team constantly works to evaluate the effectiveness of all of our initiatives in place. We look to identify any pain points or pressure points in our trend, and then we collaborate and strategize with our partners to help find solutions, because we want to be good partners with our PBM and our TPA.
Hey, Laura, it's Vicki. Thank you for that. And I think you've got about 2 minutes if you have time to cover the site neutral.
Okay, that would be a good one. The site neutral pricing that we have in place on the medical side, I think one thing that's important to note on the state health plan is that we do direct contract with both our facility and our professional providers. We've done so since, I think, 91 and 92. That allows us to provide more control over pricing and meeting budget requirements. So starting in 2016, we did move our reimbursement for certain services related specifically to radiology, lab, and endoscopy that were performed in the hospital, and we moved those down towards the hospital setting. Now, we didn't do it all at once. We've done a phased-in approach. Then we went a step further, and in 2018, we used, again, a phased-in approach to transition the outpatient pricing to the ASC surgical reimbursement. And then in 2023, we looked at moving PT and E&M codes and physician-administered medications, often done in a non-hospital setting, towards that professional schedule. I'll say, as mentioned earlier in the presentation, we do find this to be a successful approach. One, because we've had very little, if any, feedback from our providers. So we feel like that phased-in, stepped-in approach has worked, and we just haven't gotten a lot of feedback from them. So we feel like that's a good initiative that we put in place.
Okay, well, great. Thank you for highlighting that specific initiative, and to both of you for highlighting your programs and all the interesting things you're trying to do at the state level to try to affect healthcare costs while maintaining good quality for the patients and for your members. So we have a good 10 minutes for some questions and answers. We do have a couple already in the Q&A that I'm going to throw over to Galen, and then we can open it up for some additional questions and answers. So Galen, you have a couple questions from people about how who determines the provider's tier in your tier program, and how often is that sort of refreshed? And secondarily, when it comes to rural communities, how is the approach with the tiered networks ensured equitable access to providers at the cost favorable tiers?
Great, thank you for those questions. So first, we use an actuarial consultant. We use Deloitte, and they perform a number of functions for us, including maintaining our claims data warehouse and performing annual total cost of care calculations and determining relative efficiency scores. They use the prior year's claims data. Sometimes they have to go back a couple years in some cases. But after they do that initial analysis, they assign, working with us, they assign all primary care clinics in our network to one of 4 cost levels. And we send out letters to every single one of those primary care clinics across the state. And we do offer them an opportunity to buy down to a lower cost level, usually through a fee schedule reduction, but we do have some risk share arrangements that we offer as well. So after that process concludes, we then determine appropriate access across the state. And we have a standard that says within 30 miles driving distance from every work site, we guarantee a cost level 2 access clinic. So we do have to go through the network and move clinics that are actually naturally higher cost down to a cost level 2 access to ensure access in rural areas. Just like everything else in healthcare, things are harder in rural parts of Minnesota. One thing that can be challenging is for providers that don't have enough member months to be credible from an analytics standpoint, we group them into regional categories that are collectively assigned a cost level, typically independent providers. And then we ensure at least a cost level 2 primary care clinic. Obviously, like specialty care can be much more challenging and might necessitate longer driving distances. But for that initial primary care clinic, which then of course determines cost sharing for everything else for a member for the rest of the year, we do guarantee access to that within 30 miles of each work site.
That's great. We have a question also for Laura, and feel free, Sabrina, Karen, Laura, to come on to camera for the Q&A section. Laura, somebody asked more specifically about the program for the GLP-1. They didn't really understand the description that you gave about the GLP-1s and the discontinuance. Can you maybe go into a little more detail on that?
Oh, sure. With the patient assurance program, the way it was brought to us is they identified initially 5 products, and they said that the PBM said, let me say that, who they is, but the PBM brought this program to us, and we adopted it as a way to address the high cost of insulin that was going on nationwide. Now, we have 2 options under the state health plan. One is a PPO based, one is a high deductible health plan. So this program was probably more beneficial for those folks in the high deductible health plan, in that instead of paying 100% of their prescription costs until they hit their deductible, the cost of those drugs was limited to $25. Whereas under the standard plan option that we have, the PPO, the copay that was in place was $42. And so we limited their cost, the members' cost, to $25. And the money to fund that, it was our understanding, was really being absorbed by pharma. So it allowed our members to have access program. It added products as after the program was implemented, and there was a lot of GLP-1s that became eligible for that patient assurance program. And once that happened, it really, the cost that we noticed were more folks were going to brands. We weren't seeing the outcomes and the results of probably better care for those diabetics, thinking that they'd be more compliant with their medication. We removed some barriers to cost. So that was the concept of the plan. And once we did our analysis where we didn't see the outcomes that we had hoped, and with just the explosion of those GLP-1s, it became a much bigger program by default. So we just saw a lot of growth in those brand products, which cost is involved in that. Or we noticed the increase in the price of those costs that the plan was having to absorb.
So that sort of leads to another question that somebody asked, which is very related. So how are both states really handling the costs of the weight loss drugs?
We don't cover weight loss drugs. So that is a very specific plan exclusion for us. But having said that, we noticed that there were some prescriptions that were being filled that we couldn't confirm a type 2 diabetes diagnosis. And we went in and we identified providers that were prescribing these GLP-1s where we did not see a confirmed type 2 diabetes diagnosis. And it kind of ties into the evaluation of the PCMH and those low value services. We noticed that some of our patient-centered medical homes were in that list of providers. So we've tightened our PAs that are in place around the GLP-1s and just trying to make sure that they are appropriately administered for type 2 diabetes, because the weight loss is a very specific plan exclusion for us.
Thank you for that. Galen, do you want to chime in on what you're doing on the weight loss drugs?
Sure. So we use CVS Caremark for our PBM, and we use their standard formulary, which does mean that there are some formulary covered GLP-1s authorized for weight loss purposes, and there are other GLP-1s that are authorized and covered for diabetes treatment only. And we're still in the middle of really digging into the data. I mean, certainly it's been an increased cost to the plan, but the extent of that cost is something that we're still trying to puzzle through right now.
Okay, we have another question here it's coming in through the Q&A. And this one may be more targeted to Laura again. When you're, and both of you could chime in though, when evaluating programs like the PCMH models, are you coming to agreement on your evaluation methodology prior to implementing the program or not? And do you have any idea if any of the monies in the program are flowing through to value-based contracts with any downside risk in them?
You know, I don't know if we have any that have. Actually, I think we might have two bigger hospital-based systems that have the up and downside cost sharing, but they are two of the bigger hospital systems in our state. But yes, we are working very closely with our actuary as well as our TPA, which is Blue Cross of Blue Cross Blue Shield of South Carolina. We are working with them in partnership to evaluate this program and see how it will continue with the state health plan and for our memberships. But we are looking at addressing the cost sharing for our members, because there are so many, and there's really a provider incentive to be in to be a part of the patient-centered medical home. So we're looking at all things, all options are on the table, and Blue Cross has been very cooperative in working with us on that.
Good. Thank you so much for that. I know we're running right up to the hour, but there is a question I'd like to ask Sabrina and Karen. You mentioned in your survey that there's somewhat limited documentation of states' initiatives resulting in cost containment. Can you clarify if that's really a reflection that whether this initiative did not result in cost containment, or an indication of sort of how hard it is to measure the work going into cost containment? Or is it neither of those things?
Yeah, no, it's primarily the latter, Vicki. It's a great question. The question on the survey was whether they had been able to whether the state had been able to document any return on investment from the cost containment initiative, and we had only 15 states report that they could do that. And that by that we mean, you know, we meant and we interpreted the responses to mean that they could identify actual dollar savings from the program. But I think what we've heard was that the inability to do so was largely due to a lack of access to data or analytic capacity. So it's an under-resourced area, but a very important one.
Well, thank you for clarifying that. And I know we've reached our time, so I just want to thank everybody for a great discussion. Thank our speakers who came on today for the very creative work they're doing, especially that creative work with the TPAs. And we want to recognize the work that all states are doing, this important work to address costs through state employee health plans. And we will continue to work with state employee plans to support your efforts to address costs and improve the plan performance. So thank you all for joining us today. Thank you for our sponsors and our speakers. And with that, we'll end our webinar. Thank you.